What the Study Says.
Welcome back to What the Study Says. I'm Dr. Kai.
And I'm Dr. May.
We are diving deep today into a topic that is far more common, complex, and emotionally charged than most people realize: female pattern hair loss, or FPHL.
And our source is the absolute gold standard. It's the latest clinical practice article right out of the New England Journal of Medicine, dated October 16th, 2025.
So this is as current as it gets.
It really is. And to make this really practical, we're going to frame our whole analysis around a classic case vignette from the article.
Okay, let's hear it.
It's a 46-year-old premenopausal woman. She walks into her doctor's office with a 3-year history of this progressive, steady thinning.
So it's not a sudden thing.
Not at all. And she's otherwise healthy, but she does mention, she has mild hirsutism.
A bit of excess facial hair.
Exactly, that she's been plucking. And crucially, no recent major health changes, no new medications.
Okay, so our mission for this deep dive is clear. What does the most authoritative medical literature say to do for this patient and millions like her?
And before we get to treatment, we have to just state how incredibly common this is. We are not talking about some rare condition.
Not even close.
No. FPHL is statistically the single most common cause of hair loss in women. The numbers are just staggering, and they really scale with age.
How much do they scale?
So for women of European descent, you're looking at maybe 3 to 12% in their 20s and 30s.
Okay.
But then you look at women over 70, and that number it skyrockets to 56%.
56%. Wow. That's more than 1 in 2.
More than half. It completely changes the conversation. This is, it's a public health issue.
Absolutely. And are there global variations?
There are. The article notes that prevalence is lower in Asian women, hitting somewhere between 12 and 25% over 70.
Still significant.
Oh, yeah. And for women of African descent, the numbers are, they're a bit fuzzy.
Why is that?
Because the clinical presentation often overlaps with a scarring condition we'll talk about later called CCCA.
Okay, so let's unpack the core mechanism. What is actually happening at the scalp level?
The defining feature for all pattern hair loss is a single process: progressive hair follicle miniaturization.
Miniaturization, meaning everything is just shrinking.
Exactly. The hair structure itself is shrinking. A healthy scalp has these thick terminal hairs, over 60 micrometers thick.
Right.
In FPHL, that same follicle starts producing hairs that get shorter and thinner with every cycle. They shrink down toward what we call vellus hairs.
Which are tiny, right? Almost invisible.
Less than 30 micrometers. So it's like a factory that's still running, but it's constantly downgrading the quality of its own product.
And this messes with the entire hair growth cycle.
It severely disrupts it. The active growth phase, which we call anagen, gets much, much shorter.
So less time spent growing.
And more time spent resting. That resting phase, telogen, gets longer. And what's really interesting is the NEJM article highlights this additional quiet phase after telogen.
Another phase?
Yeah, it's called Kenogen.
Kenogen. This is a new one for a lot of our listeners, I bet. What's the significance?
So think of it this way. A healthy follicle rests for a bit, then boom, starts growing a new hair.
Right.
In FPHL, when a hair sheds, the follicle goes on this long, unannounced vacation. That's Kenogen. The pore is just empty for an extended time.
So you've got this triple whammy: fewer hairs growing, the ones that are growing are thinner, and they take way longer to be replaced.
And that's what creates the visible thinning.
So if someone's looking in the mirror, what are the classic visual patterns they should be looking for?
The hallmark is decreased density right in the central scalp. It often starts near the front, what we call frontal accentuation.
But not all over.
No, and this is a key diagnostic clue for doctors. The hair on the occiput, that's the back of the head, is almost always spared. It doesn't progress to complete baldness like in many male patterns.
And I know clinicians have names for these patterns.
They do. The two main ones are the Ludwig pattern, which is sort of a diffuse thinning over the crown.
Right.
And the Olsen pattern, which is often called the Christmas tree pattern.
Christmas tree?
Yeah, because the thinning is widest at the very front hairline, and then it narrows as it goes back.
This all leads us to the big paradox of FPHL, doesn't it?
Mm-hmm.
For years, we called everything androgenetic alopecia.
Meaning it's caused by androgens, male hormones?
Right. But this NEJM article, it tells a much messier story.
It really does. For men, hair loss is pretty straightforward. It's genetics and androgens, but FPHL is multifactorial.
Hormones, genetics, and environment.
A complex interplay of all three.
Okay, but let's start with the androgen connection because it does still exist for some patients.
It absolutely does. The mechanism is there. In affected scalps, we see more androgen receptors and more of an enzyme called 5-alpha reductase.
And that's the enzyme that converts testosterone into the much more potent DHT.
Exactly. And you see this mechanism being very active in patients who show other signs of androgen excess.
Like our 46-year-old case patient with the mild hirsutism.
Precisely. It's especially common in early onset FPHL. The data is pretty striking, actually. Over 80% of women with both FPHL and hirsutism will have high androgens.
So for them, it is an androgen story.
For them, it is. But here's the twist. Here's where the whole story gets flipped on its head.
Okay.
Most women with FPHL do not have excess androgens.
Wait, say that again?
The vast majority of women who present with FPHL have no clinical or biochemical evidence of androgen excess at all.
So if it's not the androgens, what is it? We have to rethink the whole cause.
We do. And the article points a finger towards estrogen. It turns out, in the affected parts of the scalp, there's a decrease in an enzyme called aromatase.
And aromatase is important because
It helps regulate local estrogen and testosterone levels. So if it's decreased, you could get a localized hormone imbalance right there in the follicle, even if your blood tests are totally normal.
a local problem, not a systemic one.
Exactly. And here's the final nail in the coffin for the purely androgen theory. FPHL has been seen in women with complete androgen insensitivity syndrome.
Meaning they are biologically unresponsive to androgen.
Correct. The hair loss is happening in the literal absence of the supposed culprit. It fundamentally changes everything.
Which explains the big shift in terminology.
It's exactly why. Because the androgen link is so inconsistent, the term female pattern hair loss has pretty much replaced the old androgenetic alopecia for women.
It forces doctors to look beyond just hormones.
Right.
Okay, so that brings us to diagnosis. If a doctor sees central thinning, they can't just assume it's FPHL. They have to play detective.
It requires a lot of precision. The first step is always a targeted history. Menopausal status, hair care practices, signs of hyperandrogenism,
And blood work.
basic screening blood work is key. You've got to check iron, vitamin D, and a full thyroid panel. Deficiencies there can either mimic or worsen hair loss.
So what are the main lookalikes you have to rule out?
There are three main ones. The first is chronic telogen effluvium.
That's just increased shedding, right?
Right. It's diffuse, temporary loss, usually reversible, but it can happen at the same time as FPHL, which really complicates the picture.
Okay, and then there are the more serious scarring conditions.
Yes. The second one is frontal fibrosing alopecia, or FFA. This is a scarring condition we see mostly in postmenopausal white women.
And how do you tell it apart?
You'll see a recession of the front and side hairlines, and very often loss of the eyebrows, too. It's an inflammatory process that actually destroys the follicle for good.
And if there's one?
Central centrifugal cicatricial alopecia, or CCCA. This is seen primarily in women of African descent.
It also affects the central scalp, which sounds like FPHL.
It does, but the key difference is that CCCA involves scarring. The follicular openings disappear and get replaced by scar tissue. The loss is permanent.
So when do you need to go beyond just looking and doing blood work and actually take a biopsy?
A biopsy is a good idea if the diagnosis is uncertain, if the thinning is happening really fast, or if you suspect one of those scarring conditions.
This is a definitive test.
It is. It confirms FPHL, measures the follicle density, and it can spot scarring. But here's a really crucial takeaway from the paper.
What's that?
A sign of microinflammation, this thing called a lymphohistiocytic infiltrate, is found in about 70% of FPHL biopsies.
70% have inflammation. That's an immune finding, not a hormonal one.
Exactly. We absolutely have to circle back to that for our final thought.
Agreed. But first, let's get to the main event, treatment. What actually works?
So the NEJM authors are really clear that treatment is never one size fits all. You have to tailor it.
Based on what?
Three things. Childbearing potential, whether there's hyperandrogenism and their other medical history, like a history of cancer.
And we should be honest, the quality of the evidence for a lot of these treatments isn't perfect.
No, we're lacking a lot of high-quality head-to-head trials. But let's start with the cornerstone, the one that's FDA approved.
Minoxidil.
Minoxidil. It works by pushing hairs back into the anagen growth phase and reversing some of that miniaturization.
Topically, it's the 2% solution or the 5% foam.
Right. The 2% solution twice a day or the 5% foam once a day. But, the 5% solution, even though it's only approved for men, is used all the time for women off-label because it just works better.
But let's be real, the greasy twice-a-day application is a huge barrier for a lot of people.
It's a huge adherence problem,
Yeah.
which is why the shift to low-dose oral minoxidil has been such a game changer.
Tell us about that.
It's used off-label, usually 5 milligrams a day or less, and the data is really compelling. One trial found that just 1 milligram of oral minoxidil a day was at least as effective as using the 5% topical solution.
Yeah, that is a massive clinical victory for patient quality of life.
It really is.
But if you take it orally, you get systemic side effects. What do people need to watch out for?
The most common one is some mild swelling in the ankles, peripheral edema. The other big one is hypertrichosis.
Unwanted body hair.
Right, that affects about 15% of patients. And since it was originally a blood pressure drug, there's a very small risk of low blood pressure. Doctors always start low and go slow.
Okay, moving on to hormonal approaches. This is for patients like our case study with signs of hyperandrogenism.
Yes. When you've confirmed high androgens, these are very effective, often combined with minoxidil. Spironolactone is a workhorse here.
But the dose matters.
The dose really matters. The sources say you need at least 100 milligrams a day to see a real effect on hair.
And what about things like finasteride?
So those are 5-alpha reductase inhibitors. Neither finasteride nor dutasteride is FDA approved for women.
But they're used.
They are. Higher doses of finasteride, like 2.5 or 5 milligrams, have shown success in some studies. But, and this is the most important warning in the whole deep dive,
Let's hear it.
for any premenopausal woman considering these hormonal treatments, strict, reliable contraception is absolutely non-negotiable.
Because these drugs can cause birth defects.
They can cause feminization of a male fetus. It is a critical safety checkpoint in every single conversation about these meds.
That cannot be overstated. Okay, finally, let's touch on the procedural options, the add-ons.
These are popular, but the trial quality is all over the place. The most common is probably platelet-rich plasma, or PRP.
Where they inject your own concentrated platelets back into your scalp.
Exactly. You need at least 3 initial treatments, and then you have to keep doing maintenance sessions to keep the results.
What about devices?
You have microneedling and fractional lasers, which are often used to help topical drugs penetrate better. And then there's low-level light therapy.
The hats and helmets.
Right. Those devices that use red light, usually 630 to 660 nanometers. Some studies have shown they can increase hair density.
Now, before we wrap up, there was a special note for breast cancer survivors.
Yes, this is so important. For this group, minoxidil and spironolactone are generally considered low risk and are good frontline options.
But not the others.
No, the 5-alpha reductase inhibitors and other strong antiandrogens should be strictly avoided until we have more safety data, especially in hormone receptor-positive cancers.
Okay, so let's circle all the way back to our 46-year-old patient. Thinning mild hirsutism. What's the gold standard recommendation for her?
Given her age and signs of hyperandrogenism, the NEJM article recommended combination therapy.
So, 2 things at once.
Exactly. Start either spironolactone or high-dose finasteride to tackle the hormonal side, and pair that with minoxidil, probably the oral form for convenience.
And the key is patience.
Patience and persistence. Treatment is long-term, maybe lifelong, and they should be using standardized photos every 6 months to actually track their progress.
The big takeaway here seems to be that while FPHL is incredibly common, our understanding of it is still evolving, and treatment has to be intensely personal.
That's it exactly. And despite this being the most common cause of hair loss, the evidence base for comparing treatments is, frankly, a bit shaky. We just don't have enough good trials that account for things like race, age of onset, or hormone status.
Which brings us back to our final provocative thought for you, and it stems directly from that weird data point we mentioned earlier.
Right. We treat FPHL with drugs that target hair growth cycles like minoxidil or hormones like antiandrogens.
Right.
But why, then, is a clear marker of microinflammation present in 70% of patient biopsies? It raises this huge question for the future.
Which is?
Since we know inflammation can mess with how follicles respond to treatment, is this microinflammation a huge, under-recognized, non-hormonal target that we should be going after? Should we be thinking about anti-inflammatory drugs?
Something to mull over until our next deep dive. If you found this useful, please subscribe and share this deep dive with others who might benefit from cutting through the medical jargon and getting straight to the clinical insight.
Thanks for diving deep with us. We'll see you next time.